Welcome to this new series of the Massey Dialogues. My name is Nathalie DeRosier and I'm the principal of Massey College. Massey College is located on Indigenous land, the land of the Seneca, the Huron-Wendat, and the Mississaugas of the Credit. We are grateful for their stewardship of the land and for the ability that we have to continue our work here. The Massey Dialogues are based on the idea of bringing together the voices of experts and the voices of the young researchers. This intergenerational aspect is key to the vision. We want to discuss issues of the day and hear different perspectives. I want to thank the Massey community for the wealth of good suggestions that we have received throughout the summer, and particularly to Keshna Sood and Michael Valpy and their committee for putting together this fall program. Enjoy today's discussion.
Okay. Hi, my name is Michael Valpy. I'm a senior fellow at Massey College, and I'm moderating today's session of Massey Dialogues. Today, our topic is an examination of COVID, Canada, and the old. And we're going to ask the question, what's wrong with us? Why do we have the highest rate in the world of COVID-caused deaths among the institutionalized elderly? It's more than twice the rate of the United States, which is chained around the planet. Sorry. Are we that callous as a society toward the elderly? Are we that uncaring and dismissive of the old among us? Or has there been some aberration in the evolution of Canada's healthcare system that has left long-term elderly care orphaned and fragile? And to examine those questions, we've brought together three members of the college whose scholarly interests have been social policy in general and healthcare in particular. I've chosen to give pride of place to Dr. Ito Peng because her work is in comparative social policy, and thus she can put Canada in a global context. Dr. Peng Ito is Canada Research Chair in Global Social Policy and Professor of Sociology and Public Policy at the Munk School of Global Affairs and Public Policy, specializing in family, gender, and demographic issues in migration and comparative social policy. And after an opening discussion with me, she'll be joined in conversation with Senior Fellow Dorothy Pringle, Dot, Professor Emerita and former Dean of Nursing at University of Toronto, whose research has focused on the quality of daily life of older people who are cognitively impaired and those who live in long-term care facilities and their family caregivers. And then Dot will talk with Junior Fellow, in fact, both Dot and Ito will talk with Junior Fellow Husayn Marani, who is a doctoral candidate in the Institute of Health Policy Management and Evaluation, and he examines aging with dignity and alternatives to institutionalized care for the aged. I'm hoping that Husayn will sort of fill the role of cleanup batter in baseball and discuss with Ito and Dot what viable directions we can take into the future. And so with that as an introduction, I want to give you a quote from Professor Carol Estabrooks of the Faculty of Nursing at University of Alberta that Dot sent me a couple of days ago, and it speaks directly to what we're examining. The quote reads, "The moral test of government is how it treats those who are in the dawn of life, children, those who are in the twilight of life, the aged, and those in the shadows of life, the sick, the needy, and the handicapped. The poor conditions of care in nursing homes have, with increasing frequency, been given prominence over the last 50 years in more than 100 published reports. Those reports come from all high-income countries, as Ito will demonstrate to us. But Canada has far more than its share. A quick search of the media for just the past 10 years, Dr. Estabrook concludes, yields over 150 reports in Canada alone describing unacceptable and sometimes scandalous conditions experienced by our older adults in nursing homes. They all report similar findings. They all reflect our underlying outrage. They all make recommendations. They all read, one or two actions are taken, and then they all sit on a shelf. Nothing changes, not really, not fundamentally. And what is left substantially unanswered is why. Why do we treat the institutionalized elderly this way? Is there a values issue involved? Is there something systemic or mechanical in the way our health care system is developed? So, Ito, let me ask you, what are we seeing in Canada? Why is the COVID death rate in Canada's LTC homes, long-term care homes, the highest in the world? How does Canada compare in institutionalized elderly COVID deaths with other countries? What does our death rate say, if anything, about how we value the old in Canada? And why did long-term care wind up being left out of the national healthcare system? And will you go ahead and set the stage for us? All in 30 seconds. Go ahead.
Thank you very much, Michael, for very important questions. That's a lot of questions. So maybe I could start out by just sort of giving a very brief overview of what's happening to COVID-19 in Canada, its impact on older people, and then focus onto the situation of the COVID-related death in long-term care homes. So, Matt, I wonder if you could pull out. Thank you. So, Matt, could you go to the first slide? So, this is the latest Canadian government data on the COVID-19 cases, which just came out this Monday. What it shows is that unlike a couple of months ago, COVID-19 cases are more concentrated amongst younger age groups, particularly right now amongst people between the age of 20 and 59. But if you look at the next slide, please. But if you look at this slide, what you see is that the cases of hospitalization are much higher among older people. In fact, over half of the people who are hospitalized due to COVID-19 are even now currently, people over the age of 70. So while the infection rates might not be so high amongst the older people right now, once they get it, it's more likely to be very serious. Next slide, please. And finally, if we look at this data, what you see is the number of people actually dying as a result of the COVID-19, and that what you see is that it's almost all amongst the older people. So in fact, over 70% of people who die from COVID-19 in Canada are people over the age of 80, and another 18% are people in their 70s. So altogether, while more younger people might be contracting the virus, nearly 90% of death due to the COVID-19 among people who are over the age of 70. So this is pretty significant. Having said that, most of the deaths due to the COVID-19 in Canada, that is among people over the 70, this is say similar in other countries as well. And in fact, similar patterns could be seen in other high-income countries such as the US. Next slide, please. This table was published by the Center for Disease Control in the US. It's a little bit earlier data, but what it shows is the rate of hospitalization and deaths among different age cohorts in the US. It shows that, that compared to people between the ages of 18 and 29, people aged 75 to 84, if they catch COVID-19, their chances of being hospitalized would be something like 8 times higher than the younger cohort, and the chance of them dying from the COVID-19 will be 220 times higher. And if you look at the people over the age of 85, the chance of these people being hospitalized will be something like 13 times higher than people aged between 18 and 29, and the chances of them dying from it will be something like 630 times higher. So across the countries, across different countries, COVID-19 actually impacts older people disproportionately. But what makes Canada very different from other countries, and this is the next slide, is that even though the total number of deaths due to COVID-19 in Canada is not that huge compared to other countries like US or the UK, Spain or France, the proportion of COVID-related deaths amongst long-term care home residents is very high. So when you see that circle, big red circle, this figure shows that Canada actually stands out in that compared to other OECD countries, in that about 85% of all the COVID-related deaths has been happening amongst the residents of the long-term care homes. This is quite astounding. Now, the death rates among long-term care home residents in Canada could be high, is high, maybe because a relatively higher portion of Canadian seniors actually live in long-term care homes. And in fact, I have shown in other papers that Canada actually has much higher proportion of long-term care beds per 1,000 population than other countries, much older countries demographically, like Japan, Germany, or other places. High death rates amongst long-term care home residents in Canada might also be due to the fact that long-term care homes are not providing adequate care or quality care for their residents. For example, we know from the various studies and reports that have been made public this summer that the high rates of COVID death in long-term care homes in Ontario and Quebec is partly due to the poor quality of care provided to the residents, and as well poor working conditions and low wages given to the frontline workers and so on. So there are many reasons why I think Canada's death rate amongst the long-term care home residents is really, really high. There might be other reasons, but these are the important issues that we really need to address. So, Michael, your other question about what does it say about how we value the old in Canada, I think, so just frankly, I think we don't value the old very much in Canada. I also think it's not just Canada, but perhaps other countries as well. What our data show in terms of the high death rate amongst the long-term care residents in Canada is that maybe and other data shows that I showed seems to suggest that maybe our dominant culture is sort of very much informed and influenced by the dominant economic thinking that is so focused on market and productivity. So, for example, children are seen as, say, potential future workers, and so it makes sense to invest in their care and education. But older people are basically seen as a kind of net drain on the economy because they're no longer working, and so they may not be as economically productive compared to the younger workers in the market. And so that this thinking in our culture, in society, might sort of lead to thinking that there is some kind of burden on society. But of course, what this view neglects is the fact that these older people have been contributing to the economy and society before they became old or retired, or before they retired. And many of them continue to work and contribute to our economy. And more importantly, I think it also neglects sort of the fact that they also continue to contribute to our society in many different ways. For example, they are the keepers of our historical, institutional, and cultural knowledge. They contribute to our society through their experience and insights and things like that. Many older people actually do provide care to younger people and to each other, but none of them are sort of visible because they're doing it for no pay as a family caregivers. But so I think these values, these important contributions that older people make are not being valued because they are not recognized. Particularly,
the question that still sticks in my mind is, we're supposed to be nice people, and why do we stand out on these death numbers?
I think in the case of the long-term care home, the deaths in long-term care homes in Canada, and I should mention it's particularly Ontario and Quebec, right, within Canada, not everywhere in Canada. I think it might have to do with the fact that the way long-term care systems in Canada is, of course, not part of our universal healthcare system, in the sense of it's not part of the Canada Health Act. And so it's been it's jurisdictions of different provinces. And provinces like Ontario and Quebec have decided to make long-term care homes largely privately run. And so, for example, if you look at the data of deaths in the long-term care homes, a significant proportion of that is happening in the private sector, privately run long-term care homes.
Okay.
And
is that different in other OECD countries?
Well, other OECD countries have different systems of long-term care. In that, for example, some countries have nationalized long-term care in form of long-term care insurance that are funded by the government, but it's universal, compulsive social insurance, and that it could be funded by government, it could be run by public sector or provided by private sector. But because there is a set system for long-term care, the government then has to create a kind of fairly high standard, regulatory standard for these care deliveries. The problem when you allow the system to be much more loosely private and privatized, then the regulatory mechanism doesn't operate as well. And one of the problem with the long-term care homes that we have seen in Ontario and Quebec, and many people have pointed out this, is that there isn't very good regulatory system to monitor and make sure that they're providing quality care. So, for example, this summer when the Canadian Armed Force went in to help out in some of the long-term care homes in Ontario, they came out with a report of incredible sort of awful situations. All of that, is because even though there are these long-term care homes, it seems that the service that's been provided are not really up to standard, that people are not being cared for.
Did this surprise you from your research?
I think it's not surprising, and yet it surprised me. From my research, I know that if we want to have a good long-term care system, we need to have a good regulations to ensure the quality and of care, and that adequate care gets provided. And so I knew that when there is no clear sort of public system for long-term care, it then becomes quite haphazard. There are good long-term care homes, and then there might be some bad long-term care homes. That variation is really, really big. So I knew it might be a problem, but I must say, when I read the report of the Canadian Armed Force on the long-term care homes that they went in, I was quite shocked by the details of that report.
Dot, I'd like to bring you into this. In a conversation we had earlier this week, you said to me that looking after the institutionalized old is ethically challenging. What do you mean by that?
Well, I think, frankly, from the way that long-term care has evolved in Ontario and Quebec, and interestingly, they have evolved quite separately from each other. There's not a lot of interaction between these two sectors, but nevertheless, they have reached some of the same kind of outcomes as compared to other provinces. Although I don't think anywhere in Canada would win any international competition for its long-term care sector. Some do better. BC is usually held up as a better run, better finance system. But I think it's very challenging to do good long-term care. The residents of long-term care, and long-term care has changed a lot since it really became established in the 60s and 70s. Because, first of all, we're living a lot longer. As a population, we're living longer. And so the people who are going into long-term care now are older than they used to be. Most people are at least 80 when they're going into long-term care. And because we're living longer, we're much more at risk for developing dementia. Dementia is a disorder of old people. And so about 1 in 3 people over 85 have a dementia. And about 80% of people who move into long-term care have dementia. And they're more demented now than they were a few years ago, because our waiting lists to get into long-term care are longer.
Can I just interrupt you quickly? Can you compare the profile you've just given me with who was going into long-term care in the 60s and 70s?
Okay. Well, in Ontario, I think it was in the 70s when the system changed, there were two kinds of homes. There were nursing homes, not very many of them, and homes for the aged. Nursing homes were under the mandate of the Ministry of Health. Homes for the aged were under ComSoc, Community and Social Services. And there was a decision, and the Community and Social Services population were largely a lot of women, largely widows or single women, who were frail, but nevertheless independent. And genteel is the word that comes to mind when I think of homes for the aged. The decision was made to essentially merge these two systems under what is now known as nursing homes and put it under the Ministry of Health. I think that was a bad decision. I thought it was a bad decision at the time because it oriented then nursing homes much more to the health side, the healthcare side of living, as opposed to the daily life and the quality of daily life of living. And so while we were emphasizing the healthcare, over the decades since that, we have continued to undermine the services and the qualifications of people who are delivering care in long-term care. 90% of care in long-term care in Ontario is delivered by personal support workers who are competent at what they do, but they have such heavy workloads, usually about 12 residents a day is what a workload is. And you have to remember, half of these people are middle to older women who are providing this care. And so the focus has really shifted from the quality of daily life and what's going on. And we have very few residences now where there are staff recreational therapists. You don't find very many of them there, occupational therapists, or people who are dedicated to the quality of life. And so the focus of care has shifted to getting through the day. And meanwhile, the demands of the residents have increased tremendously, given that the majority have a dementia that increases over the time that they're in long-term care. They require an enormous amount of assistance with just the activities of daily living. And in some of the same research, you referred to Carol Estabrooks out at U of A. She has a huge research program under TREC, Translating Research into Elder Care. And her team has demonstrated that most healthcare aides or personal support workers will tell you that at the end of the day, they have to leave undone several essential elements of what they should be doing. There simply isn't enough time. And so what we have in long-term care now is this very dependent population. And not as, and I'm trying to avoid using the word competent, because the folks who are there are competent, but there is not much expertise beyond just the fundamental personal care activities. undertaken.
Okay, can I ask Ito, has your research take you into institutions and other countries, and are you finding the same profile that Dot is talking about?
So I think what Dot raises is really, really important. So in the countries that I study, for example, that has introduced long-term care insurance, what they try to do is actually to provide a kind of spectrum of care that starts from even a very minor sort of daily living activity, issues, and all the way to the institutionalized long-term care homes. What they're doing is basically trying to provide care to people as early as possible so they don't have to end up being in long-term care homes. I think one of the problems with our system is that we provide very little support for older people, and then boom, wait until their situation is so bad that they have to go into long-term care homes, and that's a problem. And so if you, for example, Japan and Germany, both countries are demographically much older than Canada, and yet the number of long-term care home beds per thousand is about half the number as Canada. And that's because their long-term care system starts from home and with minor, relatively small things like, somebody cannot no longer do heavy cleaning at home or provide home care services and things like that. That's a way, I think, a much better way, much more humane and much more actually rational way to support and provide them with care so that they don't have to end up being long-term.
I see Husayn nodding his head. Are you going to get to that in a second?
Mm-hmm.
I can comment on it now, actually. This kind of relates to my own research, where I do think that at least in Ontario, it's not all doom and gloom from a care of the older adult population. I think we're moving towards that idea that we can encourage older adults to age with humanity and dignity in the comfort of their own home. And I think we're pushing towards that with the ideas around aging at home, policies that have been around BC and Manitoba and Ontario for a number of years now, and Nova Scotia. But to add on to that, I think that we still have a lot of room to grow.
Mm-hmm.
Ito, at the onset of your discussion, you talked about how human value is very much tied to economic contribution. And both in the context of home care and long-term care, we can see, the treatment of unpaid care workers, even paid care workers, like Dot had mentioned, personal support workers. There's a certain devaluation of them, and I think we can look towards how the treatment of care workers as a metric toward in terms of understanding the treatment of older adults in society.
That's interesting. Will you just expand on that a bit? That we can look at the treatment of PSWs as a metric?
Yeah. Well, I mean,
the
COVID-19 pandemic has illuminated the huge deficits in the organization of personal support work and health work in general, where it's clear that personal support workers exist at the very bottom of the health work hierarchy. Ito, you talked about the marketization of long-term care and healthcare, and what we've seen is this impetus and this push by Ontarians specifically, because that's the context in which we're living, that personal support workers need to be paid more. And it shouldn't simply be lip service vis-a-vis an incentive to work an extra 6 months. There needs to be certain regulations, there certainly needs to be greater protection. But because we conceptualize long-term care and also home care as these invisible settings in which the older adults simply disappear out of society and into, that reflects almost in in the devaluation of those who care for them. In this case, are unpaid and paid workers. And I think that's compelling. I think the COVID-19 pandemic has illuminated how we need to be caring for our care workers, so that they're better able to provide care for the older adults who need that care.
How does that happen? Through unionization? How do we give personal support workers the stature that you're talking about?
I mean, that conversation is happening as we speak. I think, personal support work as an occupation is one of the very few health occupations that doesn't have an occupational identity. It's not a profession per se, in terms of what we think about in terms of nursing or medicine or even law. It could be a semi-profession in terms of the fact that they still operate under they still work under certain rules and regulations of somebody who's above them in that healthcare hierarchy. They don't have full autonomy over the care that they are able to provide. So I think moving forward, we might see this push towards some kind of professionalism, whether it's semi-professionalism or some quasi type of professionalism. And with that would be, for example, as you mentioned, some kind of regulation, whether it be registry or self-regulation. I don't think that we'll move towards self-regulation, but a registry would basically entail that personal support workers have clarity around the work that they're doing. And with role clarity comes standardization and wage. And with standardization and wage comes things like better hiring procedures and more standardization across the channels in which personal support workers are hired, whether it's in long-term care or home care.
Ito, in other countries that you've looked at, is there more of a professionalization, a higher status for personal support workers?
Yeah, so I have to say from get-go, personal support workers or frontline care workers are one of the lowest paid people within the healthcare sector. There are different models to try to sort of alleviate that. But very close to us, BC, British Columbia, this year, because of COVID-19, because of what happened, actually formalized all the frontline long-term care workers into the public sector and raised their wages to the union wage. So you could do that.
Are they unionized now?
They're part of the public sector union in BC, whereas in Ontario and other places that's not the case.
I think Dot, you were telling me that in a lot of cases, personal support workers have 3 months training, or sometimes even just high school courses.
Well, there are 3 tracks. Let me say there's a high proportion of personal support workers in Ontario who are unionized. Mm-hmm. Canada is quite different than the US. Again, if we think we have a problematic long-term care sector, then we can look at the US as having even more problematic. But they did not incur the same proportion of deaths within their long-term care sector. And I have no idea why that's so. Mm-hmm. Because there's so many things that are similar, but again, our system tends to work better, and partly because there's much more unionization among the personal support workers in Canada than there is in the US. Now, there are three routes to becoming a PSW, personal support worker. That's the Ontario term, because they're called different things in different provinces. To work in the publicly supported long-term care sector, you must be a graduate of what is a 2-term program in a community college. Then there are private colleges that may have anywhere from 6 weeks to 8 weeks of training. And some of those folks work in home care. And then you can be in the home care track in a high school and become a personal support worker or a healthcare aide through a very, and I don't know exactly the number of weeks, but not much training, high school. And you find those people tending to work in the private sector, in the home care private sector. And I don't mean the private sector of the organized home care, but there's a lot of privately organized care and outside of any of the regulated sectors. And that's where you will find people prepared through the high school route or the private college route.
Would the three of you, can I put this question to the three of you? Would you get rid of private for-profit home care institutions?
Good question. I think I would say I would not necessarily get rid of them. I think it's not private or public kind of sort of zero-sum game, right? I think it's possible to have both private and publicly run long-term care. It happens in Japan and other places as well. I think the important thing is having a clear sort of universal regulatory mechanisms that would ensure that both private and public long-term care homes and services are provided by sort of certain people with sort of good wages, and people who are trained with good wages, and that the quality of the services or quality of care is sort of ensured and monitored and respected.
And
Michael, can I?
And would you achieve that? Yeah, go ahead.
Well, I was going to say, Pat Armstrong, who's done probably more research in this area than anybody else. Pat's at York University. Pat feels very strongly that the only way to get the quality of care is to move this entirely to a public sector. Yes. and eliminate the private. I think when you there are some excellent private for-profit homes, and there are some terrible homes that are in the not-for-profit charitable sector. And so I agree with Ito that we don't have good regulation. And in Ontario, we have screwed up the inspection system so badly. It wasn't in great shape, but the current government really eliminated probably the best of what it was. And so without regulation, and I think in the Royal Society report, what they say, we're regulating the useless and not regulating the useful. And so it's just on the organizational side of things, I think long-term care in Ontario, and probably put Quebec into that basket of wet as well, are a mess.
Mm-hmm. What would good regulation mean? Bringing all these institutions under national health legislation, under a Canada Health Act? Are the homes in Japan, for example, Ito, are they regulated by national health legislation?
So in the case of Japan, for example, what the government did was create a new stream of social insurance called long-term care insurance. So Canada has, for example, a national Healthcare Act, which provides national medical insurance for everybody, right? And so what Japanese did was, well, they do have universal national health insurance in Japan. What they did was, instead of changing that, simply brought in a new health insurance, called long-term care insurance, a care insurance. The reason for them doing that was that the national health insurance was already very big and very focused on health. Long-term care, they knew right away, was more than just health. It's about social and health care. And therefore, they wanted a new stream of national insurance that will cover everything, that part. So it's attached, and then runs like national health insurance. You get payroll deducted, the premium get deducted from your payroll, the whole, just like pension or health insurance, right? It's and it runs fine, and that there's a lot of permeability between the two. So once once a person is over the age of 65, or if you begin to have age-related illnesses after age 40, such as dementia, then you can move from sort of national health insurance and as well into the long-term care insurance.
Interesting.
Yeah.
Husayn, where would you take us? You're going to be out there in the next generation very shortly.
Yeah. Well, I have so many visions for where we could take us. To be quite honest, I'm very optimistic with the future of long-term care, of home care, of the treatment of older adults in society. Very quickly, though, I wanted to comment on something Ito just said. Was, I smile because I think a long-term care insurance would succeed and address a lot of issues in home care right now, because at least what I argue in my own thesis is that the shift from institutionalized care to home care under the auspices of aging with dignity and the economic incentive has actually shifted the financial burden, for lack of a better word, on our unpaid caregivers. So costs of caring that were otherwise absorbed by the government, by the public, are now disproportionately incurred by our unpaid caregivers. So this idea of an insurance plan that captures care, both medical care and also aspects of social care, would be really important in a context like Canada, where we do have both the existence of long-term institutional care and then long-term home and community care as well.
Is any province doing that now?
Like a long-term care insurance?
Yeah.
I'm not sure. Ito, do you know the answer to that?
Not that I know of. Yeah.
Okay. Sorry, I didn't mean to interrupt you. Go ahead.
No, I was just going to say, I think moving forward, as a resident millennial on this panel, I feel compelled to offer some optimism. And I think, when we look towards the treatment of older adults in society, I think there's a certain, the importance of intergenerational solidarity, at least from my perspective, is extremely important. That during the pandemic, one thing that really was very obvious was this bias towards, in our language and discourse, was this bias towards younger people. The idea, for example, of social distancing versus physical distancing, it precludes older adults from the conversation. It really, we know that loneliness is a significant killer among older adults living in institutionalized care. And so when we're pushing for this idea of social distancing, all the while opening up businesses, we need to be cognizant of who's actually being compromised here. Who's actually shouldering this responsibility for distancing? It is older adults. In Italy, for example, this idea of distributive justice, where at least at the beginning of the pandemic, older adults were, quote unquote, asked to not go on ventilators so that those ventilators could be used for younger people, is again, it creates these language and this discourse of ageism. And when I think about, I really enjoy this one definition of ageism by Anna Karf, the sociologist. She says, ageism is prejudice against our future selves. And I think that rings true very much for me as I look forward to my own future and I reflect on, would I want to be treated this way? And we live in a very technologically advanced world. And something I'd love to see as far as intergenerational solidarity is concerned, and this shift in discourse around inclusivity of older adults, is using technology and leveraging the fact that technology can help older adults as well. We've seen the digitization of learning and schools. Can't we digitize aspects of care and socialization in the context of long-term care? And I'm sure Dorothy and Ito, you have some comments on this. What do you think that we could do as a younger generation to facilitate the inclusion of older adults moving forward in society?
First of all, have lots of children. Well, it's a huge problem because our demographics are changing, and we have people are having fewer children and living longer, and those two things are incompatible, frankly, because we are dependent. Older generation is dependent on their children to provide some care, at least, or to be helpful to them. Very often people who can stay home on home care are being supported by daughters. Let's be very clear, they're daughters. So have lots of children and have the larger proportion of them be daughters to assist. And I think what we haven't talked at all about is this dementia as a huge issue in managing our the older population.
80%
of admissions. Yeah, 80% of people going into long-term care have a dementia at some stage. If we had a breakthrough in dementia in terms of either finding a prevention or an effective treatment, it would change the picture of long-term care. And I think we need to, there's a lot of work going on in this area, a terrific amount of work, but we still haven't really cracked that in terms of an effective treatment, at least, so that people can be more independent and safe into their very advanced old age. So it's another complicating factor. If you take dementia out of the picture, long-term care would work very well. We'd have an overcapacity. But
did anyone predict that by living longer, we were going to get this epidemic of dementia? Did you know this was going to happen?
Well, I think it's crept up on us. I don't know the answer to that question, Michael, but it has crept up on us. I think there's some I'm sure some scientists in the dementia area who would be able to answer that question.
I think the Dot's answer about having children is quite fantastic, but I wonder how realistic and how possible it is. I could well imagine younger people going, whoa, I need to work, I need to have family. I think maybe it would be ideal if people feel like they would love to have more children, but put that aside, I think a couple of other things might be that we might want to consider. One is really to think of care rethink about care, the ethic of care, as a part of our social and political theory, right? So, people like Joan Toronto has talked about care as more than just sort of in private, personal, of things, but care as a part of social fabric that we need to care, and it doesn't matter. It should go beyond our own family members. That intergenerational solidarity means that we, as a member of society, should understand that care is part of our sort of social moral obligation.
Wait, what would that look like, Ito?
Well, so what it would look like, it would be something like, that care becomes part, just like, as a part of democracy, right? We vote. It's part of it, it's a part of democratic principle. Maybe part of our intergenerational solidarity is that we begin to provide care much more closely in our neighborhoods, in our communities, as a part of civil engagement.
Like the school co-op systems, only better organized and more focused.
Yeah. I think that will make people recognize the importance of care. And it would do more than that. By recognizing that importance of care, we could begin to revalue the value of care work. Because right now, as Husayn has said, and as we've been saying, a lot of care is being done, mainly by family members, women, daughters, daughter-in-laws, ex-daughter-in-laws, all these people. And none of that is valued. It's considered zero in the economy because it makes no economic contribution, according to the mainstream economic theory, that is. I think it's because our culture, our economic theory refuse to recognize the value of that care. And because of that, we then think care is a cheap thing, because that's why we pay care, frontline care workers, PSWs, very little money, because it's not valuable. I think we need to change that mindset.
You would agree, Husayn?
I would agree 100%. Yeah, it comes down to reorienting our way of understanding of older adults in society and how we treat them. It almost requires a reconceptualization of our social contract. What are we responsible for together as a society to sustain the functioning of all members of society?
Yeah.
But how do you legislate that? It's very difficult, isn't it? How do you legislate goodness?
Yeah, good question.
Well,
Good question, yeah.
I think we as Canadians think we're pretty good about this. We tout this kind society that we have. We're kinder than a whole lot of other people out there. I would like to see that premise tested, particularly. But I think we have to put our money where our mouth is and acknowledge that we are shifting, that because we're living longer and because we have this vicious thing called dementia, and I keep going back to it because it's the driver in long-term care in Canada. It really determines how much care people require, and the skills that are required. Taking care of people with dementia is highly skilled because they're very fragile. But I think we have, until that gets cracked, that we do have to capitalize on this concept of kindness and turn it into something very concrete. And we have to be prepared to look after somebody else's mother or father, because we're dispersing ourselves as families. And so we can't necessarily get the care from within our own family.
Folks, we're out of time. I hope you've enjoyed this as much as I have. And thank you so very much for contributing your time for a wonderful discussion. Bye now.
Thank you.